Hi, everyone. Good afternoon, and thank you so much for joining the training today. This training is hosted by the Ohio Chapter American Academy of Pediatrics with support from the Ohio Department of Health. So we thank ODH for their support and partnership with this program. This training is part of the Preventive Health program that has topics on emerging health issues, child health issues, and will be a quality improvement project starting in December. So if there are any primary care pediatricians who are interested, or NPs that are interested in participating in the quality improvement project, please let me know, and I can give you more information on that. If everyone could please make sure that their lines are muted and their cameras are off. Thank you all so much. And go to the next slide. Our speaker today is Dr. Rupa Thakur. She's a pediatrician at Cleveland Clinic, and she is also the Lead Free Ohio medical director.
A free donut with any drink.
Just some more information on our preventative health program. We have 2 resources created, one for families and one for physicians for each of the trainings that we have. There's a total of 12 trainings on various topics. I know a lot of you all have been here for a lot of the trainings. Those trainings, recordings, and then as well as the resources are all available on our website, and you can access it there. Our next training is on oral health on July 21st with Dr. Jim Duffy. So if you're interested in that topic, please feel free to register for the next training. These are the new resources that we have available for this training, one for physicians and one for families. And we also have the family handout that will be available in Spanish, and all of the other handouts are available in Spanish as well. At this time, I will go ahead and pass it over to Dr. Thakur to get us started. If there are any questions throughout the training, please put them in the chat box and Dr. Thakur will answer them at the end. There is 1 CME and 1 MOC credit available for this training, and a survey will be sent out on Monday. And if there's any questions, please feel free to email me or let me know in the chat box. Dr. Thakur?
Yes, thank you. Happy Friday, everyone. Thank you all for joining us today. I'm very excited to be here. As primary care pediatricians or providers, we all recognize the value of well child checks, but sometimes the recommendations can feel very overwhelming, both in terms of the volume of screenings that we're asked to do, as well as understanding the rationale behind them. So today, I'm hoping that we will clarify why the screening schedule is as it is, cover some techniques to complete all of these screenings efficiently, and review some panel management behaviors that can improve our completion rates. Next slide, please. So a quick poll question just to get a sense of who's in the virtual room with us today. Which of the following best describes your primary practice site? Private, academic, community, or other? All right, so it looks like the majority are community practices, which is great. Next slide, please, Alex. So regardless of where we work, the purpose and components of a well child visit should remain fairly constant. with the mission to promote and improve health, education, well-being of infants, children, adolescents, families, and communities. So this is a tall order and somewhat vague. Let's break this down a little bit more. Next slide, Alex. Bright Futures calls out 4 domains or tasks that a well visit should achieve. The first is prevention, including vaccines and anticipatory guidance around safety and nutrition, as well as infection prevention during something like a pandemic. The second is tracking growth and development, including a review of developmental milestones, social behaviors, and learning. The third is addressing parental concerns, which can sometimes take up the majority of our time in a well child visit, but often overlap significantly with the topics that we aim to cover when reviewing age-appropriate anticipatory guidance and development. And finally, we aim to foster relationships. So we know that regular visits create strong, trustworthy relationships between pediatrician, parent, and child. So this team approach helps develop physical, mental, and social health of a child over time. Next slide, please. So why do we pack so much into our well child checks? Because we know that quality preventive care can decrease overall healthcare costs and increase healthcare outcomes, as we see fewer hospital admissions and reduced emergency department utilization when patients and their families have a trusting relationship with a primary care provider who can address their concerns on an ongoing basis. So this results in improved value in terms of healthcare spending, quality metrics, and a caregiver's perception of the value of their child's visit at the pediatrician's office. So if we're addressing their needs, all of their needs, both medical and non-medical, parents are more likely to feel that these visits are meaningful, their providers care for them, and that they can trust their provider's recommendations around potentially divisive topics like vaccination or weight management. Next slide, please. Well, let's break this down a little bit more. What are the key components of a well child visit? Next slide. For the visit to be successful, the needs and agenda of the family must be addressed. So the first priority is to address the concerns of child and parent. The health supervision components are listed here. Overall, the well child visit should be unhurried with adequate uninterrupted time set aside for questions and discussion. We take a history to assess strengths, accomplish surveillance, and enhance the provider's understanding of the child and family to guide their visit together. This should include a discussion around diet, elimination, sleep, and dental hygiene. For adolescents, this should include a HEDS assessment as well. Developmental surveillance occurs with every well child encounter and includes both developmental milestone assessment and review of growth charts. A standard brief review of systems is an effective way to ensure that any additional significant problems are identified and addressed in that visit. Health supervision activities should also include observation of the parent and child interaction. So many of us do this without recognizing it as a key part of the exam, but we will pick up on tension between a sullen teenager and their overbearing parent, or a rambunctious child and their frustrated parent. Sometimes it's more subtle though. Maybe a new mom that isn't bonding so well with her baby, prompting a discussion around postpartum depression, or a child with chronic complaints of abdominal pain with a markedly anxious parent in the room. And so you start to kind of put these things together. Or maybe a child with speech or social delays who is handed a phone as soon as they walk into the room and is kind of focused on a tablet for the entirety of their visit. So you kind of see that social interaction is lacking. We recognize that some of these behaviors or activities might be persisting at home, and that reading activities might be lacking. And so this might prompt a discussion of how they can read together. How many books do you have in the home? How often do you visit the library? So watching that interaction between the parent and child can sometimes help us identify concerns and potential interventions that may have otherwise gone unacknowledged. The physical exam should be comprehensive, yet also focus on specific assessments that are appropriate to the child's age, developmental achievements, and any specific needs or concerns identified in the history. Beginning in middle childhood and by adolescence, policies related to privacy and confidentiality should be established and reviewed for both the child and the family. By about the 7 or 8 year visit, it is appropriate to offer the option to have part of the visit without the parent present. And most healthcare professionals will always excuse the parent from that maybe the exam part of the visit by about the 12-year visit, just to give the child a little bit of privacy, to allow them to ask questions on their own, and to get them used to conducting at least small parts of their visit on their own. Recommended screening and immunizations occur at every well child visit. Screening tasks were chosen on the basis of available evidence or expert opinion. So I'll go into detail on some of those in a moment. Assessing the completeness of a child's or adolescent's immunizations and offering any vaccines that they might be due for is a key element of these visits. The value of immunizations in avoiding preventable diseases and disease complications is an important discussion for providers to have with parents, because we know that parental anxiety and misinformation often needs to be addressed at these visits. So spending a little bit of time on that is helpful and necessary. Bright Futures uses the CDC and Prevention National Immunization Program and the AAP's Red Book for up-to-date immunization schedules. So that's where the vaccination recommendations come from. And finally, for each visit, anticipatory guidance is organized into 5 additional priorities by Bright Futures, designed to focus the visit on the most important topics for a child of this age. So I'll show you what this looks like. Next slide, please. For those who might just be vaguely familiar, Bright Futures is a national health promotion and prevention initiative led by the American Academy of Pediatrics and supported in part by the U.S. Department of Health and Human Services, Health Resources and Service Administration, Maternal and Child Health Bureau as well. The Bright Futures guidelines are designed to provide theory-based and evidence-driven guidance for all preventative care, including screenings and well child visits. So I want to show you an example of what the Bright Futures Guide looks like for a well child, because I think it could be very helpful for all of us in terms of our own practice as well as teaching our trainees. Next slide, please. So this is the Bright Futures Guide for a 4-year well child visit. You can see that it outlines some specific age-appropriate milestones to assess for, as well as recommendations for what to look for in the parent and child interaction. So does the parent allow the child to answer questions? If offered books or toys during the exam, does the parent let the child choose? It prompts you a little bit about what to look for. Next slide, please. The next page reviews special considerations for the physical exam, in this case, a formal motor assessment, then summarizes the universal and selective screenings that a child may be due for. So in this case, universal screening should be offered for hearing and vision, oral health for those without a dentist. Selective screening might include anemia, dyslipidemia, lead, oral health, TB, depending on the child's risk factors. Links to the CDC and AAP's immunization schedule and other resources are offered next. And then we get into the sections on anticipatory guidance. So within each of the 5 priorities highlighted for this age, the anticipatory guidance begins with a brief description for the provider of why this is important and what we're looking for. So in this case, the description for social determinants of health is risks, strengths, and protective factors, and includes examples of each. Then there are sample questions and anticipatory guidance points, which provide a possible script for discussion and help frame a relevant conversation with the family. And you can adjust these questions and guidance as appropriate for your population that you're dealing with, or if you know specific things about this family and want to adjust a little bit. This is just a place to start and gain a little bit of comfort in having those conversations around issues that may not have been on your radar previously. Next slide, please. So here you can see a few other topics relevant to social determinants of health with scripting provided and embedded resources. So an example here is, within the past 12 months, were you ever worried whether your food would run out before you got money to buy more? Within the past 12 months, did the food you bought not last and you didn't have money to get more? So if this line of questioning raises a concern for food insecurity, the prompt to refer to WIC or SNAP is there for you, just as a reminder of what resources might be available. Similarly, hotlines for tobacco cessation and domestic violence assistance are provided for easy reference as well. Additional priorities for the 4-year well child visit include school readiness, which you can see on the bottom right there. Next slide, please, Alex. So school readiness, we see healthy nutrition and habits. Next slide. And then media use and safety. So in 5 pages, Bright Futures outlined for us all of the key components of the 4-year well child visit. So if you haven't spent some time with the Pocket Guide yet, I encourage you to do so when you have a spare moment in the office. It's a really great resource for those who teach as well. If you want to review what needs to be covered prior to entering a patient's room, or review after they've gone in to see which parts they hit and which parts they might have missed. And if you have access to the full manual, even better. There's additional information in there around screening guidelines and evidence-based practice. Next slide, please. So let's review some of these screening guidelines together. Today's presentation is not meant to be a comprehensive list of the screening recommendations from Bright Futures. Instead, I chose several recommendations that have either been updated in the past 5 or 6 years, or may involve some nuances that I thought were interesting and worth reviewing. So next slide, please. A quick pop quiz. A fasting lipid profile should be ordered at all 15-year well child visits. True or false? Let's see what we think. All right, so we're kind of split on this one. The answer is actually false. And I'll tell you a little bit more about that in a moment. Next slide, please. So before we jump into the specifics, I just wanted to share the Bright Futures periodicity schedule, which has all of the screenings on one page, color-coded by age, and indicates whether the recommendation is for universal versus selective screening. It's hard to see when it's so small, but if you have a blown up version of it, you'll see that there are solid dots versus stars, and that tells you whether it's universal or selective. Other caveats to screening are listed in the footnotes below. Again, very small on this page, but if you have the option to blow it up, you'll see a lot of that information there. So this is another great resource to have in the office for quick reference and to share with your trainees as you teach. Next slide, please. So the 4th edition of the Bright Futures Guidelines was published in February of 2017 and included quite a few updates to the previous recommendations. So these included the addition of universal prepubertal cholesterol screening, universal depression screening over the age of 12 years, universal HIV screening in adolescents, universal maternal postpartum depression screening, newborn critical congenital heart disease and bilirubin screening, oral health screening and fluoride varnish application, and universal adolescent hearing screens. At that time, the recommendation for annual pelvic exams under the age of 21 years was eliminated. So these changes were made in 2017. Let's look at a couple of these recommendations in more detail. The next slide, please. Bright Futures recommends universal screening for anemia at 12 months of age, but selective screening can be performed at basically any time based on risk factors. So for our premature or low birth weight infants, or those with early introduction of cow's milk, you can consider testing at 4 months of age. So obviously we don't recommend cow's milk that young, but if it has happened, it's not a bad idea to check. For those with a low iron diet, such as a strict vegetarian diet, or with food insecurity or other environmental factors, you can consider testing annually. For adolescents with menorrhagia or a previous history of iron deficiency, you could also consider annual screening. Regardless, all non-pregnant females of childbearing age should be screened every 5 to 10 years. So again, universal screening for anemia at 12 months of age, but selective screening can be performed at any time based on these risk factors. Next slide, please. Universal blood pressure screening should occur annually over the age of 3 years, but can be considered at younger ages based upon risk factors. These include personal or family history of kidney or urologic disease, transplant, prematurity or low birth weight, and medication or chronic medical conditions known to be associated with increased risk of hypertension. Next slide, please. Developmental screening includes 2 parts. Universal autism-specific screening should be conducted at 18 and 24 months, and universal general developmental screening should be performed at 9, 18, and 30 months. So there is consensus within the AAP and with others regarding the value of early detection and intervention for developmental delays, including gross motor, fine motor, communication, and social development as the 4 domains that we think about. Surveillance, even by experienced parents and healthcare providers, can miss cases. So this is why in 2006, the AAP recommended developmental screening at specific ages, in addition to surveillance at every well-child visit. All children, most of whom will not have identifiable risks or whose development appears to be on track, should receive these periodic developmental screenings using a standardized test. Bright Futures doesn't recommend a specific screening tool for either of these, but many practices choose the MCAT for autism-specific screening, and either the Ages and Stages questionnaire or the Survey of Well-Being of Young Children for the general development screening. So you may be familiar with some of those. There are other options though, so I won't get into the weeds on any of the specific screening options. These recommended ages for developmental screening are suggested only as a starting point for children who appear to be developing normally. Surveillance should continue throughout childhood, and screening should be conducted anytime concerns are raised by parents, providers, or others involved in the care of the child. Next slide, please. All right, so switching gears a little bit, dyslipidemia. A fasting lipoprotein profile, so that includes total cholesterol, low density and high density lipoprotein, cholesterol, and triglyceride. So that panel should be obtained once before pubertal onset, so typically 9 to 11 years, and once in late adolescence, so 17 to 21 years. Screening should be considered for younger children when risk factors like a family history of MI or stroke under the age of 55 in males and under 65 in females, or a history of familial hypercholesterolemia is identified. Similarly, if a younger child has diabetes, hypertension, obesity, so BMI over 95th percentile, you can consider measuring a fasting lipid profile in those situations as well. Next slide, please. Recommendations for screening for sexually transmitted infections are kind of complex, but the basics are listed here. The populations included as high risk may be slightly different for each individual infection, but in general, we're referring to unprotected vaginal or anal intercourse, multiple or anonymous sexual partners, having sexual partners who are HIV positive or injection drug users, exchanging sex for drugs or money, those in adult correctional facilities, or sex with partners who engage in any of those high-risk activities. All sexually active females should have a yearly gonorrhea and chlamydia screening. In contrast, sexually active males may warrant screening annually depending on their risk factors. So these include regional infection or spread rates. And I'll be honest, I tend to just order them on all of my male patients as well, because we know that a lot of those infections can be asymptomatic. And so waiting for symptoms to develop may not always be the best option. Those patients engaging in high-risk sexual activity should be screened every 3 to 6 months for gonorrhea and chlamydia. Selective screening for syphilis should be performed for those engaging in high-risk activities. Youth at increased risk for HIV infection, including those who are sexually active, participate in injected drug use, or are being tested for other STIs, can and should be tested for HIV and reassessed annually. Bright Futures recommends, or the recommendations follow the USPSTF, and they ask for HIV screening once between the ages of 15 and 18 years, making every effort to preserve confidentiality of the patient. So that's where that universal screening recommendation comes in. Next slide, please. The lead screening can also be confusing, and I know this better than anyone with my work with the Lead Free Ohio program. Ohio law mandates that we must order a blood level at 12 and 24 months for any patient that is on Medicaid, lives in a high-risk zip code, or answers yes or don't know to any other question on the Ohio Department of Health's lead screening questionnaire, which we typically will administer every year at well child visits from 12 months to 6 years. If we see a child between 3 and 6 years of age who is on Medicaid or living in a high-risk zip code, but never had a lead level done before, we should order a lead level at least once. And finally, you should continue to test yearly for any child that has a yes or don't know response to any other question on the questionnaire, as that could indicate ongoing exposure. So if your site is using capillary sample collection, please know that any elevated blood lead levels must be confirmed with a venous sample. The CDC recommends blood testing for all refugee children who are 6 months to 16 years of age upon entering the US. So for some of our clinics in the region where we do have high refugee and immigrant populations, this is something to consider. Repeated blood lead level testing for all refugee children who are 6 months to 6 years of age, 3 to 6 months after they are placed in permanent residences, should be considered a medical necessity, regardless of the initial test results, because we know that a lot of them will move into high-risk homes when they're here in that initial period. Next slide, please. So this is not a specific recommendation of Bright Futures, but we received some feedback that a brief overview of WIC eligibility criteria might be helpful in the context of this talk. So just a reminder that pregnant and breastfeeding women, postpartum women, and children under the age of 5 who present to a WIC clinic and can provide proof of identity are residents of the state of Ohio, are determined by a healthcare provider to be at medical or nutritional risk, and are at 185% of the federal poverty income level are eligible for WIC benefits. And we've also included Help Me Grow's hotline number here as a resource for pregnant and postpartum moms, single parents, and children under the age of 3 at risk for developmental delay. Next slide, please. So WIC can be useful in providing nutritional counseling, iron deficiency anemia screening, and formula or age-appropriate foods for young children. Their website has several resources that you can share with your parents and families as well. Next slide, please. So I just reviewed some of the recommendations listed in Bright Futures, not all of them. And there's clearly a lot that we're expected to do, and we have 20 to 30 minutes to complete that work, less if your patient shows up late or you're running behind for any reason. So there's so much to do in so little time. Next slide, please. How do we do this more efficiently? I wanted to share some of my tips based on our implementation of the Bright Futures guidelines at the Cleveland Clinic, but I would love to hear ideas from those on the call, either success stories or lessons learned as we move forward with some of these ideas. So whether you're looking to implement Bright Futures as a brand new initiative, kind of revamping how you're documenting or how you're thinking about your well visits, or if you're looking to perform quality improvement around one specific recommendation, I hope that you'll find some value in this section. Next slide, please. So before we get there though, a quick poll question. Does your practice use pre-visit questionnaires? Yes or no? All right, so it looks like we're kind of split, but several practices have answered no. All right, next slide, please. So my first tip is don't reinvent the wheel. You have access to healthychildren.org and the Bright Futures Toolkit to access pre-visit questionnaires, visit documentation templates, and parent handouts addressing anticipatory guidance and common complaints. So again, whether you're looking to implement Bright Futures brand new, or if you're just looking to perform quality improvement around one recommendation, you can adopt or adapt these materials for your own practice rather than creating them from scratch. So I encourage you to use the links here and take a look at some of the resources that are available to you as templates for your work. Next slide, please. So here's an example of a parent handout available on healthychildren.org. Available on healthychildren.org. For those who are unfamiliar, healthychildren.org is the American Academy of Pediatrics parent-facing website. It houses a lot of great articles on everything from constipation management to sleep training to teaching adolescents to take responsibility for their own actions, as you can see on the screen. So I loved these recommendations for parents to do less and let consequences happen. Just some reassuring tips for parents to let them know that they're not being bad parents, and giving them a little bit of guidance on what to do next. Next slide, please. So tip number 2 is to engage your entire team. We know that outcomes are best, patients are most supported when they have an ongoing relationship with their provider, nursing staff, and office schedules. I borrowed this slide from our Cleveland Clinic Population Health slide deck. So some of the acronyms may be unfamiliar to you. I'll talk you through them a little bit. PSR stands for Patient Service Representative and refers to our front desk staff. So these teamlets know the patient and their history, their social situation, and their ongoing concern because they've been seeing the patient back in the office over time. They have a trusting relationship with the patient that builds with every encounter. So I know that this isn't ideal and isn't always possible. In my office, I can tell you I work with a different MA every day. So having that ongoing relationship may not be possible. But if we think about our broader team, hopefully you start to feel some continuity. We identify the members of our teamlets as our first step. Next is to identify extended team members. So on the right side of the slide, you see a diagram of what we, again, at the Cleveland Clinic call our Patient Care Service Centers, or PCSAs, in which multiple community practices, CP, report to and have access to the resources of a central family health center. So we kind of think about regionally, what is our largest site that has the most resources, and which smaller sites around them can access the resources that they have and share those resources. So that those resources might include a clinical pharmacist, social worker, care coordinator, behavioral health specialists, whoever is part of that team to help support your patients. So like I said, this is Cleveland Clinic structure, but I'd love for you to think a little bit about what resources you have access to, who those team members are who help you support your teamlet and your patient. Next slide, please. So once you know who those folks are, it's time to bring them together. Educate them on what Bright Futures is, or what the recommendation that you want to improve your metrics around is, and start to convince them of its value. The reasons to buy in are varied and numerous and can include anything from improved patient outcomes to streamlined workflows that will save them clicks or less time spent charting. So get their ideas on how best to implement the guidelines into your practice and who should be involved. And usually if they are part of the process of creating implementation ideas, they're more likely to follow through and act on them as well. Make sure that all staff members are trained on how to use the questionnaires or processes that you decide to implement. They should feel comfortable enough with these tools to assist families as needed in getting them completed. And they should have ready access to the tools and supplies that will be distributed at each visit. One way to do this might be to develop packets for each well-child visit, including a checklist of all the necessary screenings, the questionnaire forms themselves, any appropriate parent handouts that you might want to give for that age, and appropriate vaccine information sheets. So this ensures that our teams have everything they need at the beginning of a patient encounter, and that we're less likely to miss something as we go through the visit. Next slide, please. So now that you have all your materials together, who's going to do the work? This is where swim lanes can come in handy. Start with the initial entry point of a patient to your medical office and list out who they come into contact with throughout the course of their visit. Then you can delineate what each person's role might be in ensuring that the Bright Futures recommendations you're focusing on get completed. So in the example here, the receptionist gives the family their questionnaires, the MA checks that the parent completed them, the clinician reviews, discusses, and documents them, and then the MA finishes the encounter with any educational handouts or resources that the patient may be eligible for. Next slide, please. For those who need a visual, an actual swim lane diagram can be helpful for more complex processes that include multiple team members taking action simultaneously. So the example I'm actually sharing is not related to Bright Futures, so don't worry if you can't read the text too clearly. This was our workflow for reviewing the various hospital, newborn nursery, and ED discharge lists that we were responsible for addressing during our morning huddles. So I'm just using this as an example of what a swim lane looks like. But you can see that each row on the left there, you can see each row defines the role of a specific team member. So we have the charge nurse, the MA, the provider, care coordinator. And each of us in the team had a specific task that we were expected to complete in the morning, including maybe reviewing one of those specific lists that I mentioned, identifying the patients that need outreach, and reporting these in the morning huddle. From there, our charge nurse, receptionist, and care coordinator took the lists of patients requiring outreach and did their magic. So you can kind of see that their swim lanes continue and have additional tasks added to them. But it was very clear from this type of a diagram who was responsible for each part of the process and ensured that no patients were missed. So swim lanes can kind of help make these complex processes a bit clearer. Next slide, please. So tip 4 is to use your EMR to its greatest potential. Automating documentation in the chart will save your team time and minimize your risk of error. Many of my recommendations are in reference to Epic's capabilities, which uses my chart as its patient-facing platform, only because that's what I'm familiar with and that's what we've been using at the Cleveland Clinic. But you can achieve similar results with other systems. If you have a sophisticated enough platform, you can push out those pre-visit questionnaires electronically, maybe a week prior to the scheduled well-child appointment. Reschedules or same-day appointments may miss that opportunity, but the majority will still benefit from a streamlined, automated method of getting patients to complete their questionnaires on their time, not taking up time in your office. Use of a tablet device in the office or captive mode allows questionnaires completion in the office while the patient is maybe waiting for their provider or waiting in the lobby. So captive mode is an option to actually lock down most of the functions of the computer and basically turn the computer in the exam room over to the patient so that they can complete their questionnaires. They don't have access to any other parts of their chart or anything like that. They can't access anybody else's chart either. And captive mode can only be exited when the provider enters their password or ID badge to then reopen the chart. So my recommendation here is to avoid, is to avoid paper documentation wherever possible, because we know that this will reduce errors in transcribing to the chart or questionnaires getting lost in the mix, maybe ending up in the shredder before we have a chance to document them. So it's important to get these documented because you can bill for most of the questionnaires that we do, and your documentation will support your MOC4 credits as well. If you have an opportunity to build order sets or documentation templates, you can use Bright Futures as your guide. So ensure that all of the elements of the visit have a place on your documentation tool and that all screening orders are readily accessible when a provider enters the patient's chart for a well-child visit. To help prompt the use of order sets, you can build health maintenance alerts or best practice alerts. So I'll show you what those both look like as well. Next slide, please. So again, in Epic, but I know that other systems have a similar feature. This is what a health maintenance alert looks like. So when I enter a patient's chart, the health maintenance flags me that this specific patient is overdue for the HPV vaccine and will be due for Tdap and the meningococcal vaccines next year. When vaccine or blood work is ordered, this tab updates to reflect that status. And when vaccine administration or blood draw is complete, the tab updates to reflect that the care gap is now closed as well. Next slide, please. A best practice advisory or alert can look something like this. So when a patient has maybe an elevated blood test as indicated on this one, or maybe their BMI is elevated, this alert with an attached order set will pop up. The order set provides guidelines for what lab work should be ordered and at what intervals, along with any relevant referrals. You have to address it in some way to move past it. So it kind of forces you to deal with the issue. And it prompts you to add this problem to the patient's problem list. So it helps in terms of keeping their chart up to date as well. Next slide, please. And if you need help integrating the Bright Futures recommendations into your EMR, the AAP can help. There are links here with resources to get started, as well as a email address that you can contact to receive some customized help. Next slide, please. So tip number 5 is to leverage your community partners. We as healthcare providers don't have all the solutions, and we can ask the questions, but we often will feel helpless when we ask about social determinants of health or postpartum depression and the screen is positive. But what do we do with that information? We may not always feel like we have the ability to help in the moment. So one of the best strategies is to leverage your community partners who already do that work and who do it really well. So I may not be able to solve my patient's transportation issues, but I know a community agency who can help, and I can give my patient their contact information. Or I may not be able to cook meals for my patients every night, but I know multiple charitable organizations that can assist with meal delivery, or my social worker can help connect my patients to the food bank or pantries that they're eligible for. So think about who in your practice could potentially act as a liaison to the community and maintain a list of resources for your patients that you can refer back to when you identify a positive on one of your screens. And think a little bit about what the role of this person could be, including making phone calls to make those referrals, making phone calls to follow up with patients to ensure that their needs were met, or do you have access to an online platform like Unite Us that can provide some of that same feedback on whether care gaps were closed or not? And maybe think a little bit about how you can build relationships with your community partners through community advisory councils. So that's where you can kind of hear what the community needs from you, and you can learn what they can offer to you and your patients as well. So you start to build that bi-directional relationship. Next slide, please. So with this concept in mind, if you could hit next one more time as well. We start to build out our team and fit together all of the puzzle pieces that can make lasting improvements in the healthcare outcomes of our patients. Next slide, please. So tip number 6 is to optimize our billing and coding practices. Many of us don't consistently bill for many of the well child care services that are reimbursed by payers, like hearing and vision screens, depression and developmental assessments, transcutaneous bilirubins, just to name a few. The AAP has resources to help you learn how to bill effectively and get reimbursed for all of the work that you're doing with every patient encounter. So make it count. These links will take you to the Coding Pediatric Preventive Care booklet and the AAP Practice Transformation web pages. Next slide, please. So this is all great if our patients are actually coming in, but what if they aren't? You might be sitting at the office with unfilled slots or no-shows, wondering, where are my patients? Next slide, please. This is particularly vexing because we know that in terms of population health and value-based care, we are responsible for every patient attributed to us, whether they show up, could you hit next, please, Alex? Or whether they don't. And there are multitude of reasons why they might not show up. So this might be because they just forgot. They scheduled the appointment 6 months in advance and didn't put it on their calendar. They don't need a form filled out or vaccines for school, so it's not on their radar. This might be because they have competing concerns. They can't take off work during our office hours. They have transportation issues. Or this might be related to general mistrust of the medical community or fear that they'll have their beliefs about vaccines or whatever questioned, and they just don't want to deal with it. Next slide, please. Oh. We also know that the pandemic played a large part in well child completion rates falling. So CMS reported downtrends in healthcare utilization during the pandemic for nearly 40 million children, resulting in vaccination rates falling by nearly 30%. There are many potential reasons for this, including medical office policies early in the pandemic, where we kind of closed down in-office visits, fear of illness, or the perception that coming to the office for well child care wasn't worth the risk, and of course, mistrust in the medical community, again, playing a factor. Over the past 2 years, we've also seen that social determinants of health and racial disparities have come into clearer focus as those in disadvantaged populations have struggled with lack of transportation, lack of childcare for other kids in the home, unemployment, lack of health care, insurance, those types of things as well. Most recently, rising gas prices may also play a role. Next slide, please. And the effects of the pandemic on well childcare are reflected in discrete quality metrics as well. So more childhood lead poisoning is a side effect of COVID lockdowns. Lead screenings for children plummeted. Stay-at-home orders may have increased household exposure. So this was the headline of a New York Times article published in March of 2021, at which time the CDC estimated that roughly 10,000 children with elevated blood lead levels may have gone undetected during the pandemic, as we know that hundreds of thousands of children missed their routine well child care visits in 2020 and early 2021. And in Ohio, we see that Cleveland saw the most drastic decrease in screening volumes between the pre-pandemic years and 2020, with a drop of 34%, but every major metropolitan area in the state saw a similar drop. The Ohio Department of Health, Ohio Department of Medicaid, Ohio AAP, managed care organizations, and many partners throughout the state are making efforts to increase the rate of well child care completion to capture those kids that may have been missed during the preceding years, because we know that many of those children are at risk for lead poisoning, depression, developmental delays, all the things that we screen for that require early intervention for best outcomes. Next slide, please. So some strategies suggested by the Center for Healthcare Strategies to re-engage disconnected families include appointment reminders by phone, email, or online EMR platform. Some practices with an aligned community health worker can leverage that role to conduct outreach through telehealth, home visits, or in-office appointments, and CMS will reimburse for those services under Medicaid and CHIP. Some payers will offer financial incentives to beneficiaries for engaging in healthy behaviors, including the completion of well child visits. Medicaid managed care organizations can provide resources to families such as transportation to in-person child health appointments or connect families to needed social services. And as mentioned before, we can leverage our community partners to help close care gaps that are outside of our scope of expertise or that act as barriers to accessing healthcare. Next slide, please. The Ohio AAP also offers some resources that can help you re-engage your patients and their families, including provider education materials and posters, patient handouts, and up-to-date information on the pandemic. Next slide, please. So one last poll question. Does your practice have a method for identifying your patients that are overdue for well child care? Yes or no? All right, so we're about 50-50, not bad. Next slide, please, Alex. So tip number 7, if you have the ability, is to use your EMR to identify patients needing well child care for you. So many systems are now sophisticated enough to run a report of specific patients attributed to a specific provider who are falling short of certain criteria. So our system, Cleveland Clinic, created a wellness registry that pulls in every patient of a primary care provider and allows you to filter for age, vaccination status, lead screening completion, and other open care gaps. So I'll show you what that looks like in a moment. Similarly, we developed a toddler registry that narrows down the focus to patients under 15 months of age who are behind on vaccines, hoping to help drive outreach to those families that would then improve our quality metrics around infant vaccines, so the combo 10, if you're looking at HEDIS measures. Again, if your EMR allows you a platform to push messages out to your patients en masse, so we use MyChart, for example, you can send bulk reminders to these families stating that their child is overdue for vaccines and to please call your office to schedule an appointment at their earliest convenience. So you can do hundreds or even 1,000 of these at a time. If you're looking beyond well child care and want to think about management of specific high-risk subpopulations, you can build similar strategies or reports for conditions like asthma, mental health, and transitions of care. So focusing on emergency room and hospital discharges. So let me show you what a registry might look like. Next slide, please. So this is an example of the type of metrics you might see with the report, giving you a real-time glimpse into what your attributed patient panel's metrics are. If you hover over any of these metrics when you're in the system, you can see what the quality improvement goal was set at and what your numerator and denominator are. Next slide, please. So once I kind of look at that and I decide on a metric I want to improve, I can run my report and use filters to target that metric, or I can scroll through my patient panel and get an idea of where my practice is falling short. So here you can see that several patients of various ages have overdue health maintenance items. So again, this is the red flag that pops up in a patient's chart telling us that they're overdue for vaccines or other screenings. These are identified by that red oval next to the patient's name, age and date of birth there. So each red oval has a number within it, and that indicates the number of overdue health maintenance items that a patient has. So for example, here I have a couple patients that have 7 overdue items. So those might be ones that I would focus on a little bit more. If I hover over that number, I can see exactly what those items are. Next slide, please. And then using filters, so you can see where this blue arrow is on the left, you can target a specific age, a specific screening or vaccination, or just overdue health maintenance items in general. And then I can generate those bulk messages that can be delivered by email or through my chart to inform families that their child is overdue. Or I can generate a telephone encounter for a specific patient and document my conversation with the family or my attempts to reach the family. So sometimes that works a little bit better for those patients with several health maintenance items that you really want to get them in for. Next slide, please. We know that building registries and other resources within the EMR takes both time and money. So how do you get your leadership's buy-in? Next slide, please. We know that we are actively moving or have moved from a volume-based fee-for-service model to a value-based payment model. So this means that our reimbursement will no longer be dependent on how many patients we see in the office, but on the quality of care we provide, on our vaccination rates, on our weight management counseling, on our ability to keep children out of the emergency department by managing their concerns proactively or preventively. Next slide, please. And as we improve the quality of care we provide, enhance the perceived value of our well child care visits, and improve patient experience, we can lower the overall costs of care, and we expect to see increased reimbursement from our payers. Building our teams and building the appropriate technology and practice resources will allow us to see that increased reimbursement, which can then be reinvested into the practice to further improve our resources. Next slide, please. So our key takeaways today are to use available vetted resources. There's no need to spend time and energy reinventing the wheel. Please take advantage of the resources provided by the AAP and Bright Futures to make this transition easy. Be sure to engage your entire team and give a role to everyone. We know that we can't do this alone as single providers or nurses. We all have a role to play, a part to play in providing quality care, and should all be operating at the top of our license. Optimize the use of your EMR to streamline work. Don't use paper questionnaires if you can automate pre-visit questionnaires through the EMR. And finally, leverage the experience and the expertise of your community partners, help close care gaps and mitigate social determinants that you cannot do on your own. Next slide, please. I've included a few links here to the Bright Futures periodicity schedule, the evidence and rationale document for our current Bright Futures recommendations, the pocket guide, and the coding booklet. I'm happy to take questions if there are any, or just hear thoughts from the group on what's worked for your teams, what hasn't worked, share some ideas.
If anyone would like to unmute now, you're welcome to, or you can type your thoughts or comments and questions into the chat box, but we would love to hear from you. with any thoughts about Dr. Decor's presentation. Thank you so much for taking the time to present today. And please let us know if there are any questions or comments at this time. If they're not, that's okay too. I know it's Friday and it's nice out today. Well, at least here. The presentation will be shared and I will put it on the website that I had shared at the beginning of the presentation. And I'll also send it out in the follow-up email on Monday with the survey. Any other questions? All right, well, it doesn't look like there's any questions or comments. If anything comes up or you think about anything after the presentation, please feel free to send your questions to me and I will pass them along to Dr. Decor. And if that's everything, I think we can head off to our weekends. Thank you so much again, Dr. Decor. And
Thank you for having me.
yeah, everyone have a wonderful weekend and please let us know if we can help with anything.